Mm. Uh, Topic of my today's seminar is neuropsychiatric implications of epilepsy. First of all, what is epilepsy? Epileptic seizures are sudden involuntary behavioral events associated with excessive or hypersynchronous electrical discharges in brain. Relationship of psychiatric disturbances to epilepsy. The psychiatric manifestations of epilepsy are heterogeneous disorders with potentially different causes. The first is pathology itself could be the source of seizure and behavioral changes. Example, left hemisphere or temporal lobe lesions may be associated with interictal psychosis. Ictal and subictal epileptiform activity may promote behavioral changes by facilitating limbic sensory association or changing the overall balance between excitation and inhibition. The absence of function at seizure focus, thus leading to dysfunction or downregulation of associated areas. Seizure result in neuroendocrine and neurotransmitter changes such as increased dopaminergic or inhibitory transmitters and decreased prolactin, increased testosterone, or increased endogenous opioid, all of which affect behavior. The psychodynamic and the psychosocial effects of living with epilepsy, such as dependence, learned helplessness, and low self-esteem, and anti-epileptic drug-related behavioral changes. Now, the patient with seizure may have psychiatric symptoms that occur during the seizure itself, that is ictus, between the post-ictal abnormalities and the next ictus, that is interictal period, and in the peri-ictal period, which is the period just before or after the ictus. First is prodrome. Prodrome is a pre-ictal symptom that can mimic psychiatric illness. Seen in 7 to 20% of the patients with epilepsy. These are subjective symptoms that occur for 10 minutes to even days leading to seizure. They are gradual in onset and prolonged duration. These are ill-defined, non-specific feelings of malaise, headache, tiredness, confusion, anxiety, irritability, and dysphoria, which can mimic a psychiatric. The next is aura. Aura is a portion of seizure that occurs before consciousness is lost and for which the memory is retained afterwards. It is conceived as a sign of focal seizure onset. So aura which mimic or present a psychiatric illness include auditory, aura like elementary hallucinations or illusion, visual like flashes of light, olfactory sensation like pleasant or unpleasant odor, gustatory sensations like pleasant or unpleasant taste, fear, anxiety, panic attack, deja vu, that is the feeling of familiarity, and zymistry, that is the feeling of unfamiliarity, forced thinking, and emotional loss. Now, the ictal psychiatric resolution. The complex partial seizure is complex partial seizures has three components: aura, automatism, and altered consciousness. So, CPS is the most common seizure variety, affecting at least 65% of the epilepsy patient. CPS arise from temporal lobe in 60% of the cases and frontal lobe in 30%. The mesial temporal lobe sclerosis is the most common cause of epilepsy in CPS. So the automatism. Automatism is a more or less coordinated involuntary motor activity occurring during a state of clouding of consciousness, either during or after seizure, followed by amnesia for that. So automatism can be of varieties like oro-elementary, in which there will be chewing, lip smacking or swallowing movement, ambulatory like walking or cycling or running movements, and verbal like whistling, grunting, humming, repeating words or form sentences. So in temporal lobe epilepsy, the temporal lobe epilepsy present as fumbling behavior such as lip smacking, hand rubbing, picking at object, walking in circles, repeating meaningless phrases, undressing, macropsia, micropsia, gustatory or olfactory hallucinations, which can mimic a psychiatric illness. Now, most partial seizures, they last for several seconds to minutes. But in epilepsy partialis continua or partial status epilepticus, seizure lasts for 30 minutes to hours. The patient demonstrates hours of neuropsychological reactions such as thought disorder, language impairment, and changing sensorium, which may be labeled, which are so bizarre that they can be labeled as ictal psychosis. In frontal lobe epilepsy, the patient presents with repetitive hand movement, kicking, bicycling movement, hopping, jumping, abnormal posturing, head and eye movements to one side, and shouting and now, these were the conditions which mimic psychosis. Now, post-ictal psychosis, it is is the most common post-ictal neuropsychiatric symptom. Its prevalence is 6 to 10%. It is a brief self-limiting episode of psychosis that are abrupt in onset and followed by seizure. The psychosis always occur after a non-psychotic post-ictal period of 12 to 72 hours. That is a lucid. Duration is short, like mean 3.5 days, which ranges from 16 hours to 18 days. Now, Loxdale and Toon's criteria for post-ictal psychosis. This criteria says that the episode of psychosis should develop within 1 week of seizure or cluster of seizures. The psychosis lasting at least 15 hours and less than 2 months. The mental state characterized by delirium or delusion, example, paranoid, non-paranoid delusions or misidentifications, hallucinations like auditory, visual, somatosensory, and olfactory, hallucinations in clear consciousness. There should be no evidence of a history of treatment with antipsychotic medication or psychosis within the past 3 months, any anti-epileptic drug toxicity, and EEG demonstrating non-convulsive status, and a recent history. There should be no recent history of head trauma or alcohol drug intoxication or withdrawal. Severe agitation warrants hospitalization and treatment with benzodiazepine or low-dose antipsychotics. 14 to 20% of the patient with recurrent post-ictal psychosis will develop into chronic interictal psychosis after several years. There is no prophylactic role of any antipsychotic to prevent chronic psychosis. Now, other post-ictal mood disturbances that include depression, anxiety, and mania. A post-ictal depression, it lasts longer than other post-ictal states. Symptoms range mild to severe, may involve suicidal behavior, and it is common if the focus is right-sided. Post-ictal anxiety symptoms are less common, and post-ictal mania include overactivity, irritability, disorganized behavior, disinhibited behavior, and which are brief in duration. Then comes interictal disorder. Interictal disorder are psychiatric syndromes that occur between the common in periods between seizures. Depression, anxiety, psychosis, all are common, with depressive disorders being the most prevalent. Interictal hypomanic or manic symptoms are uncommon. Now, interictal psychosis, if the prevalence is 3 to 7%, it is not temporarily related to seizure activity, mental state characterized by delusion, hallucinations, and clear consciousness. Any bizarre or disorganized behavior, thought disorder, personality change, negative symptoms of schizophrenia, or affective changes are not commonly seen. The mean age of onset is 30, that is after a mean duration of epilepsy of 10 to 15 years. Episodes of relatively longer duration usually last for more than 1. Now, what are the predisposing factors for interictal psychosis? The focal dyscognitive seizure with secondary generalized tonic-clonic seizures, more auras and automatism than non-psychotic epilepsy patients, long interval of poorly controlled seizure, recent diminished seizure frequency, especially generalized tonic-clonic seizure of left temporal focus, and mediobasal temporal lesions, especially tumors. Psychosis, the interictal psychosis characteristic, these are atypical paranoid psychosis, that is paranoia of sudden onset, psychosis altering with seizures, preserved affective warmth, failure of personality deterioration, less social withdrawal than schizophrenia, less systematized delusion than schizophrenia, more hallucinations, affective symptoms than schizophrenia, more religiosity than schizophrenia, more positive as opposed to negative symptoms, and few Schneiderian first rank symptoms. Alternative psychosis or forced normalization. It is antagonistic relationship between psychosis and seizure, or inverse relationship between EEG and psychosis. Forced normalization was first described by landlord Heinrich in 1953. It is an electrophysiological phenomenon in which there is emergence of psychiatric symptoms on electric stabilization of EEG. The term reciprocal psychosis or alternative psychosis was given by Tellenbach, and it is a clinical phenomenon in which there is no psychosis in presence of observable seizures. Now, interictal depression, the prevalence is high, 17 to 21%. It can manifest as major depressive disorder, dysthymic disorder, adjustment disorder, depressive episodes of bipolar disorder. The clinical picture of chronic dysthymia interrupted with frequent interval of brief period of normal mood, that is interictal dysphoric disorders of epilepsy. There is prominent irritability and endogenous somatic symptoms. They have good therapeutic response to antidepressants, and suicidal risk is higher than the general population. Personality disorders, they again have high prevalence that include borderline personality, atypical or mixed personality, histrionic and dependent personality disorders, the most common being borderline personality disorder. The psychosocial difficulties like stigma, getting a job, driving automobile, maintaining marriage leads to dependency and low self-esteem. Now, there is a syndrome that is Gastort-Gassrich syndrome, which is commonly seen in uncontrolled temporal lobe epilepsy. It has irritability, stubbornness, altered sexual behavior, circumstantiality, hyper-religiosity, hypergraphia, and pseudo-philosophical claims. Interictal anxiety, the incidence greater than the general population. Panic disorder, generalized anxiety disorder, agoraphobia, social phobia, and obsessive compulsive disorder, which is rare, can occur. Common in the patient with temporal lobe epilepsy, especially in the left-sided folks. Now, sexuality. The patient with epilepsy, they experience disturbance of sexual arousal and low sexual drive. Comorbid depression and anxiety may affect the sexual behavior. 2 to 3-fold increased risk of erectile dysfunction. Possibility of subclinical hypogonadotropic hypogonadism. Anti-epileptic medication may cause erectile dysfunction, decreased sexual desire, retrograde ejaculation, and altered semen quality. Now, the anti-epileptic drug induced behavioral problem. There are few anti-epileptic drugs that may induce behavioral problems like levetiracetam. Behavioral abnormalities include psychotic symptoms, suicidal ideations, irritability and aggressive behavior. Clobazam, irritability and aggression. Topiramate is cognitive deficits and aggression. Phenobarbital is paradoxical hyperactivity, and vigabatrin and lacosamide can also cause aggression. These are my references.
Personality always severe disorder. Independent of seizure. It can be like this. The patient that is different. So one of the things that it is independently diagnosed. The patient difficult to differentiate with adequate seizure. Which antidepressants can cause seizure? status antipsychotic. I'm so sorry. Just put it on and I'm so sorry. Not high risk, but some of them reduce the serious. Working is low. Working is low. लेवल से दवाई हम एंटीएपिलेप्टिक लेवल पर काम करते हैं the other drugs like valproate and probably better. Teamwork, not only on the presenter. So it is better that you have a discussion on how you're going to present the topic and see if other people can take it. If you have something, then they can cover that. If you share with them, they have to you can add on. You see, and हमारे पास disorder. Yeah, between psychiatric any neurodevelopmental neurodevelopment. On the neurodevelopmental disorders, there is something going wrong with the brain. They will result in they have a higher. That is it. Dementia, like stroke to somebody that yes, sorry, type of seizure, complex partial. Complex partial term of use in the focal onset significant complex word complexity is complex number. I was reading I described there is no complex. My term diagnosis is that that type complex was like hallucination is that was earlier then it became conscious unconscious. Okay. It is very difficult to differentiate conscious and unconscious care. BTCS में तो होता है कि थोड़ा unconscious अनअवेयर होता है कई बार consciousness को आप complex में थोड़ी partial that is like this. On the diagnosis people they have been changed to increase the reliability. So if I call it complex, you can call it. He's not unconscious. He's not completely unconscious. He's still having some. He's some awareness. He's having reflexes. The way that's a continuous sort of boundary awareness की है किसी जैसे तो उनके साथ में cognitive है फिर motor है फिर तो that is the continuous relations. और ही टेक्स्ट से देखो रिफ्लेक्स दिखा है ये disorder runs to the longer भी है वो लोग पुराने वाले ज्यादा है बहुत पहले किसी ने क्या पता टेक्स्ट the distance is very good. Also refers to the professional research guidelines or diagnosis. इसलिए टॉपिक हमने डिस्कस किया सीधा डिसाइड पुरानी है ये सब कैसे पुरानी चलेगी आई डोंट नो हेल्सिंग में चेंज किया कि क्या हेल्सिंग इट टेक्स टाइम लोग आईसीटी 11 पे पहुंच सकते हैं डीएसएम 5 पे तो डीएसएम 5 से तो क्यों टेक्स्ट बुक्स तो जैसे क्या अपना मिला होगा आपको और बाकी तो क्या होगा टेस्ट में नॉट that way also to the DSM 5 the ICT 11 you know what is to come ultimately ICT 11 will come in all the types of schizophrenia emphasis we are leaving because it's not there in ICT 11 that's these are the seizure disorder is a very old recognizable okay. And neuropsychiatry तो आपको neuropsychiatry में पूरा ही psychiatry neuropsychiatry हर एक जो है every behavioral problem has some neurological significance okay, but this observable but you can get a question wrong question so you should be aware of this stuff. Okay, so if somebody asks, you should be aware. It is better to study this before your examiner to talk about complex partial, simple partial, etc. But you should be aware. So if somebody asks you a question, you should be aware that what is there in the if there's a neurologist, he will certainly say that this is out. Psychiatrist, maybe not. Depends upon the area of the test. So that you have for example, antidepressant, you have to know amitriptyline, norepinephrine, etc. You can't do both. But so you have to know, but you will be using exercise mostly. Arise and SNRI, that is what we are using and we will be using, but we have to know amitriptyline. Okay, what are the state by they discontinue this.
So we see it in two places. You should know what you have to say beyond just the epilepsy and symptoms, but also they suffer from neuropsychiatric implications. So we do the where and then that patient can get diagnosed because patient is under blood. She will provide almost and the good part was there's a lot of words in the presentation. but few spelling mistakes. So, overall,
Is I think good presentation. Psychiatric disorders, they're very common with epilepsy, and seizures are very common with psychiatric disorders. I think it is one of the it is not one of the most common PSS term, but most allowing. I will say. We've seen substance abuse, withdrawal. Most of the in RTMS also we've seen couple of seizures to part of therapy, and then we're inducing seizures in ECP. So it's a vast topic which will come to your examination. One way or seizure disorders, in the seizure disorder or like the like forced normalization, it's a short term. Right, what actually happens. It is again the phenomenology terminology has changed. So earlier on they studied EEG and EEG. So if the EEG becomes normal, the psychosis returns. If EEG becomes normal, the psychosis return as long as there is EEG the normal. Or that, so that is seizure activity. The patient is with seizure. So it is just like ECP. So seizure, when there are seizures, at that time the psychotic symptoms are reduced. Vice versa. Lots of you have to study what are the safer drugs with seizures, including special population. Seizures are very common in young population. So what you have to give there, right? And every means other psychotropic treatment for the patient is depression is maintained psychosis. Seizures we have seizures in the later stage can precipitate labor. So seizures we have to related to